All right, we will get started as everyone continues to join us. Good afternoon and welcome everyone to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will take a look at the challenges of a WHIM diagnosis with Dr. Jolan Walter. This is the first program in a brand new diagnosis-specific event series where we explore some of the rarer forms of primary immunodeficiency, starting with WHIM syndrome today. My name is Alyssa Creamer, and I'm the Director of Community Services at IDF. And on behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are so excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education, and we want you to remember that IDF is committed to our community, serving you as a trusted resource. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are never alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. We'd like to thank our partner, X4 Pharmaceuticals, for supporting today's Lunch and Learn program. We'll be hearing more from them later on in today's presentation. Before we begin, I'd like to point out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we're using the Zoom webinar feature, and attendees should be able to see the slides and our panelists in here, myself and our presenter. Attendees will not be able to activate their video camera or their microphone. There will also be the opportunity for questions at the end of Dr. Walter's presentation. You are welcome to submit any questions you have for our panelists as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen, but please remember to not include any personal health information. All questions will be anonymous and read aloud. A brief disclaimer, please remember that the information presented during this webinar is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and a friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn more about IDF and explore our resources, we invite you to visit our website at www.primaryimmune.org. Our website offers a wide variety of online and printable resources for anyone seeking information or support for PI. This includes the Patient and Family Handbook for Primary Immunodeficiency Diseases, which provides medical information and has many chapters dedicated to specific issues and conditions related to PI. It's intended to help our community and provide them with tools to enhance their communication process and better understand the information they receive from their healthcare team. We encourage you to visit the IDF Resource Center, where you can find all IDF publications, videos, news, and more. IDF also offers monthly programming and events. In addition to these Lunch and Learns, we also host 2 IDF forums a month. We host Get Connected groups, which also link participants with other individuals and families affected by PI in their local community. You can view a list of all IDF events that are upcoming on our website at primaryimmune.org/events. We're also thinking of ways to bring the latest in PI to you, such as the 2022 Primary Immunodeficiency Conference scheduled for later this year. Please save the date for October 6th through the 8th, 2022. More information will be available on our website soon. And now, without further ado, I'd like to introduce our speaker for today, Dr. Jolan Walter. Dr. Walter is the Robert A. Good Endowed Chair and Division Chief of Pediatric Allergy and Immunology at the University of South Florida and Johns Hopkins All Children's Hospital, as well as the Associate Professor in the Department of Pediatrics, Medicine, and Molecular Biology. She's also at the USF Morsani College of Medicine and is the director of the Jeffrey Modell Diagnostic and Research Center for Primary Immunodeficiency. Welcome, Dr. Walter.
Thank you so much, Alyssa. Can you hear me?
Yes, I can hear you just fine.
All right. Well, welcome, everyone. Thank you so much for joining us today for a special seminar on WHIM syndrome. And I wanted to introduce this syndrome with my own personal journey with this disease. I'm a pediatric allergist immunologist, also take care of adults. And when I was training at Harvard, I learned about WHIM syndrome in our books, but it didn't make a lot of sense to have this very interesting constellation of warts and low immunoglobulin, infection, and myelokathexis. I will talk about the details, but it was very confusing to me as a fellow. And when I asked our attendings, what do you think about this disease? They told me, most likely you're not gonna see it. So of course, it proved them wrong that by now, in the past couple of years, in collaboration with many of the centers around the world, we actually could create an international cohort of over 65 patients with WHIM syndrome. And that speaks out for the importance of advocacy that we couldn't have done without the help of X4 Pharmaceuticals, IDF, the Jeffrey Model Foundation, and many of the doctors and colleagues that we share patients with around the world. So this talk today will be a testimony for an important advocacy between many different layers of our medical field, and hopefully you can spread the word in case you have a patient that you may have this disease. We would love to hear about them and help them with their condition. These are just my disclosures. And as I mentioned, I have been consulting with X4 Pharmaceuticals, who actually has a medication in clinical trials for this syndrome, which is very exciting. And the first part of my talk will be about just the overview of the disease, because many of you may not have heard about WHIM syndrome in depth. So we're gonna go through each presentation one by one, and then I will give you some ideas about how to find these patients early in life and what could be the challenges in keeping them safe throughout their journey with the disease. So WHIM syndrome is basically a constellation of warts, and it unfortunately can lead to cancer, HPV cancer, hypogammaglobulinemia, infections, and myelokathexis. This is a Greek word for showing the retention or accumulation of neutrophils in the bone marrow. And the reason why they accumulate is because the receptor, the CXCR4 protein in the membrane of the neutrophils is overactive, and that overactive signal will prolong the maturation of neutrophils in the bone marrow, and they will not be able to home to the periphery. What is known is that there were so far 11 known pathogenic mutations defined for WHIM syndrome, and in our new cohort, we actually find additional ones. And this will be of high importance when we think about how to find patients with the disease, that we actually have genetic approach to find WHIM syndrome. But unfortunately, there is no approved targeted therapy for the disease. So as with other disorders in immunology, sometimes we have to take care of the different features of the disease, but the root cause, the reason why they have the disorder, and that treatment is missing in many cases. And that's the same in WHIM syndrome. However, there are medications in clinical trial. So what do we know about the heterogeneity of the clinical syndrome? And what I mean by heterogeneity is that every patient, even in the same family, may present with different clinical features. Beside the main features, the warts, hypogam, infections, and myelokathexis, I want to emphasize that in young age, most of the patients will have only recurrent infections. And that is a very non-specific sign. And it takes time for patients to develop the warts, and only in half of the cases, or the hypogammaglobulinemia in 70% of the cases. So as I mentioned in the slide here, not all patients present with all the 4 characteristics at given time. And therefore, you don't really have to have all 4 characteristics to have a diagnosis. Most of the time, we actually base the diagnosis on 2 important tests. One is this bone marrow biopsy, when we look for a unique cell type, the neutrophil being over mature. So they have hyperpigmentation and hypernucleation of the cell with some filamentous connections. And we also can look for the genetics, the gene defect behind this disease. And that really takes me to the genetics, which can be sometimes daunting for patients and physicians. And what we learned about WHIM syndrome is that gene defect, CXCR4, can be inherited already from one parent alone. So in this figure, there is mom and dad is unaffected, and mom has a mutation, and she's actually affected by the disease. So she has a 50% chance of passing it on to her children because she has one normal and one abnormal chromosome. And in this case of this couple, basically every second child of the family could have WHIM syndrome. As you mentioned, there is no clear genotype-phenotype correlation. So just by having the genetic disease doesn't mean that every patient in the family will have the same clinical presentation. But again, the inheritance is relatively high because just having one parent with the disease can already produce potentially 1 in every 2 child the disease. So what is happening specifically in this syndrome? As I mentioned to you, the neutrophils will be having this CXCR4, this molecule overexpressed signaling very high amount on the surface of the neutrophil, and that will keep them in the bone marrow and not let them to move to the periphery. And whatever neutrophils will go to the periphery, they actually will be over mature, and that will create them sort of maybe more prone for death, which we call apoptosis. So there will be overall a decreasing number of circulating neutrophils and lymphocytes in the periphery that will be coming to you as a test on your CBC or complete blood count as low ANC, low absolute neutrophil count, and low ALC, or low absolute lymphocyte count. And most importantly, the absolute neutrophil count can be as early as at birth of the child. So it could be a very important biomarker of the disease early in life. When we look at the cellular immunopathogenesis, we have to think about the syndrome both having a lymphocyte and a neutrophil component. And all of these are contributing to the clinical features, the infections, the hypogam, and the warts. And most importantly, patients who are diagnosed, they have to sort of meet certain criteria. As I mentioned to you, most of them would have low neutrophil count, low white blood cell count. Some of them will develop impaired vaccine responses and hypogammaglobulinemia. And all these problems will predispose them for infections and infectious complications that are listed in the middle of the chart. I'm not gonna go through that, but you can see that beside the regular infections, there could be even just infections around the teeth, periodontal disease. And unfortunately, if the disease is untreated or unrecognized, it can cause long-term or life-threatening consequences. We call them end organ disease, such as bronchiectasis, when you have damage to the lungs, COPD, and different forms of cancer. Children who get recurrent ear infection from this disease could actually have very early hearing loss, and that's a unique feature of this disease, that they have a really progressive problem with hearing. We know that the warts, which is the first initial in the WHIM syndrome, is HPV associated, and it would probably resurface later in life. Sometimes children in school can have a couple of the warts in the hand and feet, and then adults will develop genital warts. And this can be extremely impairing with their quality of life. I had families where the child could not walk on their feet or hold things in their hand because of these warts. The hypogammaglobulinemia is also very intriguing because depending on who's going to see the patient first, it may not be treated immediately. Many of our patients who come to the immunologist would probably get immunoglobulins if the patient also has poor vaccine response and infections. But once they go to the hematologist, sometimes the hypogam could be unnoticed for a while or not immediately addressed. And regarding the infections, infections are quite common. I would say around 40 to 50% of the cases would have some level of infection. And the ones that we really want to avoid are the lower respiratory tract infections or pneumonias, because these are the disorders that can end up with the bronchiectasis, the inflammation of the lung that is an end organ damage. Also, the upper airway infections can result in chronic ear infection and hearing loss. So this is the myelokathexis that I mentioned to you before. These images are nicely showing how hypervacuoled, these little vacuoles like blebs in the middle of the neutrophils. Their nuclei are hyper-segmented and there are little thin filaments sort of connecting them. And as interesting and telling it looks, it's actually very hard for the pathologist to find these neutrophils on the biopsies. So it's not uncommon that it would not be properly interpreted by a pathologist who is not trained well enough on WHIM syndrome. Currently, the European Society of Immunodeficiency have some guidelines for the diagnosis of WHIM syndrome, and that is basically taking into account the low neutrophil count that can present from birth, even without infections, and the combination of that with myelokathexis based on a bone marrow biopsy specimen. However, we know that myelokathexis evaluation cannot or do not happen in many of our patients. So there is a probable and definitive diagnosis in case the patient gets a genetic testing. And I believe that that's a very important step in the evaluation process. Or if the patient displays two of the following symptoms: warts, lymphopenia, low IgG, or parents with history of neutropenia or warts. So these are all alternative ways of raising the eyebrows of a clinician for a possible diagnosis of WHIM. And against a very nice guideline from ESID, I still believe that many of the patients are underdiagnosed or not coming to the attention of the physicians, because some of them will not be seen by an immunologist, but they may be seen by a dermatologist, an OBGYN doctor, a primary care physician, or a hematologist. What has been exciting to me as a pediatrician and somebody who is very interested in newborn screening is that we realize that WHIM syndrome patients may actually be identified by the newborn screening process. So some of you may be familiar with the fact that the most severe form of immunodeficiency, SCID, can now be detected around the country with an assay called the TRAC, T-cell receptor excision circle. And this is directly identified from the tiny blood spot that the babies give to us at the very early birth, right after birth. So what we have learned is that during the period of newborn screening for SCID in the United States, we were aware of 6 patients born in this country, and half of them had low TRACs. And the beauty of this finding is that basically gives us some reassurance that these patients could be coming to the clinician's eye even before they develop the warts, even before they have end organ disease and hearing loss, and be identified in time. And what we could also publish in this paper is that when you combine the low TRAC levels with severe neutropenia, your likelihood of finding WHIM is becoming very high. So we would like to have clinicians consider evaluation of patients with low TRAC and neutropenia for WHIM syndrome, especially if there's any family history or other features of the disease resurfacing. So what is happening in WHIM syndrome? During the course of a patient's life, there are overactive and underactive immune abnormalities that we can detect. And our experience is coming from this large international cohort of 65 patients that we collected through close collaboration with physicians around the globe. And as you can see that it was a very racially diverse population, including children, but also adults. And many of our patients actually had de novo mutations or new mutations that we have not identified in the past. As expected, most of the patients had infections. And interestingly, the patients who were identified by newborn screening were less likely to have infections than those who were diagnosed by clinical signs. And what it tells us that when we find a patient right around birth or very early in life, there's much more attention to every event that is happening to that child. And that would potentially decrease the likelihood of an infection getting out of control, to become chronic, or to cause admissions. So it was very telling to us to say that any patient that we should really find as early as possible in their life. But we also learned that the natural progression of the disease starts with neutropenia. So many of our patients will have neutropenia at the beginning with combination of infections. And then the hypogammaglobulinemia and warts are coming much later in life, somewhere around school age. And the patients who were diagnosed below 1 year of age because of family history or newborn screening were found with the neutropenia already at 6 months of age. So what you can see here is that by being aware of the diagnosis, the neutropenia itself became more evident as well. So again, early advocacy and awareness for this disease would allow us to find the neutropenia in time and bring the patient to the attention of the immunologist. We also learned, and it was not surprising, that the young patients will have less of the warts and hypogam whereas adults will have more of the 4 features of the disease. And most of them require genetic testing to confirm their diagnosis. And only half of them actually had myelokathexis evaluation by the bone marrow biopsy. What was interesting to us, beside the typical immunological features that we described with the WHIM syndrome, is that there was an increasing prevalence of autoimmune and hyperinflammatory complications that were not described in the past, such as a fraction of our patients had cytopenias, low red blood cell count or platelet count, endocrine disease, skin disease, hepatitis, and arthritis. And the cytopenias were not only affecting one type of blood cells. Sometimes it was a combination of both ITP, low platelet count, with hemolytic anemia, which sort of makes it even more complex because these patients who have multiple lineages, they may get even more immunosuppressive medications, and not knowing what is the underlying disease may not help with the right choice of the medication. So when we talk about morbidity, I mentioned to you that we can see a lot of problem with hearing loss early in life or bronchiectasis later in life, and that can really cause supplemental oxygen need and reduce lifespan. We also are worried about cancer in this population, especially with the warts. Many of the patients who have HPV could develop cervical dysplasia and carcinoma, even oropharyngeal cancer. And we are fortunate to have HPV vaccination in our country, and we hope that by using the vaccine, maybe we can prevent some of these complications in the WHIM population. Regarding additional malignancies, there were other type of diseases that were resurfacing, especially lymphomas and basically blood disorder-based cancers. And the biggest study is actually coming from the French Severe Chronic Neutropenia Registry, when they looked at 24 patients with cancer. And they had a very detailed analysis of why, how many and what kind of cancer is evolving in the patients, which is mainly affecting adults, as you can see here. So the current management of WHIM syndrome, unfortunately, is still focusing on the features of the disease, but not the root cause. And what I mean by that is that, of course, we will give antibiotics for those who have infections. We will use antivirals for the herpes flares, immunoglobulins to reduce the recurrence of infections. And we can also use G-CSF or Neupogen to increase the level of neutrophils. However, this is only going to basically bring out more neutrophils from the bone marrow, but not fixing the problem of neutrophil development in the bone marrow. So what is a novel treatment approach that is in research phase is CXCR4 antagonist. And what happens with that is that when you have an overactive receptor that would just signal heavily to the inside of the cell, one way to help with that is to calm it down by using an antagonist. This antagonist would bind and block the binding of the actual substrate CXCR12, and that would downregulate the signaling. It would help the receptor to get inside of the cell, so it's not in the surface to get all the other signals. And eventually, it would improve the mobilization of stem cells and neutrophils from the bone marrow. So currently, the only medication that has been trialed by IV medication is called Mavorixafor. And Mavorixafor is actually FDA approved to mobilize stem cells from the bone marrow, but they are not specifically approved for this disease. However, Mavorixafor was trialed for WHIM patients and has been in clinical trials since. There's a second medication called Mavorixafor, and actually I miswrote here the Mobozil, and this is an oral administration. It's not FDA approved, but there are currently clinical trials. And the advantage of this second medication is that it's oral, so it would be easier for patients to take it. And potentially, it could be a good alternative to the IV version. So as you can see on the line here, there are several clinical trials that has been linked to both Mavorixafor and Mavorixafor, which is the next one. And I just want our patients to be aware of all these trials that are ongoing. So in case there's interest, you know who to contact and how to contact them. It's always useful to go to the website called clinicaltrials.gov, where you can search for either the drug itself, or you can search for the sites, and that way you would understand if you have something going on around you, and who are the PIs who are running these studies. And I sort of listed here on the right side a couple of the PIs who were listing the latest study. We are also excited that there is a phase 1b clinical trial to use the CXCR4 antagonist for any kind of patient with neutropenia and chronic neutropenic disorders. And we actually are serving as a site for that here in Florida. This would really broaden the applicability of using CXCR4 antagonism, not only for WHIM, but other patients with neutropenic conditions. So in summary, WHIM syndrome is a rare autosomal dominant primary immunodeficiency disorder with no approved therapy. As we know, the patients have pathogenic variant in the CXCR4 gene, and that process will result in the retention of neutrophils, lymphocytes, and monocytes in the bone marrow, and therefore they will not be in the periphery, and the patients will have low neutrophil count and low lymphocyte count with sometimes inadequate function. The features is Warts, hypogam, infections, and Myelokathexis. However, this acronym doesn't reflect the broad spectrum of disease and the onset of disease, because we actually see infections before the warts would come. The clinical manifestations are associated with significant morbidity and mortality. And those who are diagnosed early through newborn screening or family history tend to do better. And therefore, we need to advocate for early diagnosis. And WHIM syndrome should be considered with any individual who have chronic neutropenia, myelokathexis, or a confirmed sequence of the CXCR4 gene mutation. Currently, management strategy for WHIM syndrome is only symptomatic, which is often not adequate to prevent all the complications. And I hope that in the coming years, we will have some solutions to that. And this is a path forward program that is going to allow patients to get genetic testing in case they have neutropenia, so they can be evaluated for WHIM syndrome or other causes of neutropenia. It's an ongoing collaboration between X4 and Invitae, and I highly recommend you to consider this in case you have a low neutrophil count and you have not been evaluated genetically. And I wanted to thank all of our collaborators internationally, our funding from the Jeffrey Morel Foundation, X4 Pharmaceuticals, the support of IDF, and I'm ready for questions.
Oh, thank you so much, Dr. Walter. And I will say before we dive into Q&A, we're going to hear a bit from our sponsor, X4 Pharmaceuticals. So while we're hearing from Michelle, if you have questions for Dr. Walter, please input them into the Q&A box. Just please remember not to provide any personal medical information, because everything will be read aloud and we will keep them anonymous. So hi, Michelle, welcome.
Thank you. Thank you so much, Dr. Walter, Alyssa, IDF, for this amazing, informative talk. There isn't a WHIM syndrome specific patient advocacy group, so information, webinars, support specifically for people with WHIM syndrome can be really difficult to find. And IDF is uniquely suited and situated to be able to provide those. And it's one of the reasons why we at X4 really appreciate the opportunity to partner with IDF and doctors like Dr. Walter to be able to provide this type of information. Hi, everyone. My name is Michelle Rhee, and I'm the Vice President of Patient Affairs and Advocacy at X4 Pharmaceuticals. I have some slides that I'll share, but I'll keep it super short so that we can get to the Q&A. And I'll just sort of tell the story of X4, the company, so that if you're not familiar with us, you can learn. This is forward-looking statements, similar to Dr. Walter's slide where she was telling about her conflicts of interest. But for X4, our mission is to develop treatments that have a clear and profound impact for people with rare diseases, including primary immunodeficiencies like WHIM syndrome and neutropenia and cancer. And the way that we want to achieve that mission is by incorporating the patient perspective into our work. We want to make sure that the patient perspective is not the only data point, but that it is a very important data point in every decision that we make. And one of the things that I love that our CEO shared with us is sort of our chosen business model in terms of how we achieve that mission. We really want to be a for-profit standalone research development and commercialization business, of course, but one that puts patients first. And the wonderful part about engaging and partnering with IDF is that you heard from Alyssa's talk, the way that IDF engages with the patient community, listens to the patient community, and helps support the patient community, does something similar, where it's that incorporation and understanding of what the patient community needs and trying to address those needs. In general, I'll sort of skip over this because Dr. Walter gave an amazing talk on this. Just sort of, there are so many unmet needs that are still in existence for anyone with a primary immunodeficiency, particularly with WHIM syndrome. And one of the opportunities we had was to do a patient advisory board with folks with WHIM syndrome. And this is just one snapshot of part of the journey of that difficult diagnostic journey, the genetic testing required. And it's one of those things that we use to help us understand that patient perspective, to help us make better decisions, to help us understand how to work better with IDF in order for us to support the right programs to help support the patient community. And Dr. Walter also touched on this, but this is just some information about the Path Forward program, the no-cost genetic testing program. You can go to invitae.com/pathforward, and you can either do a patient-initiated version of the test, where you can schedule time with a genetic counselor, or your doctor can do it. Again, in a conversation with my CEO, one of the ways that she described it was, you know, even as we're developing a therapy, hopefully an investigational therapy, we're able to help people get diagnosed, even if they're not diagnosed with WHIM syndrome. This is a panel for primary immunodeficiencies. And just being able to help someone get a diagnosis is meaningful. And so if we have the opportunity to do that, then that's just a fantastic opportunity for everyone, and a program that we're really excited to share. So that's all. I'll stop my share now and let you get back to the Q&A.
Thank you so much, Dr. Walter, and thank you so much, Michelle at X4 Pharmaceuticals, for sharing all that wealth of information with our community today. Let's dive into some of the questions that we have gotten. Dr. Walter, let's start off with one. What is the average age of diagnosis for WHIM? You spoke about newborn screening. So is it usually something that's diagnosed in childhood, or do people really struggle to get diagnosed throughout any age of life?
So the average age is probably still not in childhood or later in childhood, because as I showed you, the warts, sort of the clinical manifestation that rings the bell to most of the clinician, is not going to happen until children are in school. So I don't know the actual average age, but I would probably guess above 10 years of age at least, but closer to like young adulthood age is the average age.
Thank you, Dr. Walter. Another question, what does the care team for someone with WHIM look like? I'm sure they see an immunologist, but are there other medical professionals or specialties that they should be seeing? I'm thinking dermatology, anything else?
So the ideal setting is when you already have the diagnosis. So if you have a diagnosis, of course, you would like to have all the specialists that should line up for the complications that the patient have. If they have neutropenia, necessarily they would be looking at the hematologist, talking to the hematologist about the neutropenia. The lymphopenia and low immunoglobulin will be managed by an immunologist. And then we have to think of all the rest of the problems. If some patients have cardiac disease, they are born with cardiac disease, then you need a cardiologist. Or some patients would have the warts, again, who would need a dermatologist. Sometimes they need an OBGYN because the HPV predisposition is happening in the OBGYN region. So it is a big multi-specialty collaboration that is needed to keep a patient safe. And the key is to have the diagnosis. Until they don't have the diagnosis, they will be probably going to like one doctor and another, but not to all of them as much.
Thank you, Dr. Walter. All right, we hear from someone who is wondering, have you heard of high functioning autism level 1 as being a common comorbidity of WHIM syndrome?
I have not, but it doesn't mean that there could not be a connection. I think we are still learning a lot, but so far I did not have any data on that.
Thank you. Someone else is wondering, can you have WHIM with normal neutrophils?
So this is a good question. Thank you, Diana, for this question. When I mentioned about low neutrophils in patients from birth, it's important to also mention that when they have infections, the neutrophil count actually will normalize. And the reason is that infection would push out some neutrophils from the bone marrow to the periphery. So surprisingly, if a baby goes to have WHIM syndrome, goes to a pediatrician, they can have a normal neutrophil count if they are infected. And then between infections, when they are back to their normal baseline, they would have low ANC. So it can be sort of misleading if a child is only getting a neutrophil count when they are going through an illness, then you can have a normal neutrophil count in WHIM syndrome.
Great, thank you. Someone is also wondering, could WHIM cause chronic Epstein-Barr syndrome?
So EBV is one of the herpes viruses, and of course you need good natural killer cell function or T cell function to control EBV. Sorry about the background noise in the hospital. So I believe that you could have patients with EBV. That's why they develop lymphomas. So that is a possibility that you would have EBV in those patients. But chronic EBV syndrome itself is a very broad category. So I probably wouldn't say that every patient who have EBV should be tested for WHIM syndrome. You have to look for these other subtle signs, the neutropenia, the lymphopenia, the genetic testing to look for the full answer.
Thank you. Somebody is also asking if we could please link to the clinical trial page for I'm going to say it incorrectly, but the Malignancies. We can certainly find it and link to it, but you could also go to clinicaltrials.gov, and if you type in WHIM, you should be able to find it. Correct, Dr. Walter?
That's correct. So, and actually, I recommend for patients to go to that site with an unbiased way and just put in WHIM syndrome and look for everything possibly happening in the field, because one clinical trial could be good for one aspect of the disease, another one for another aspect. So try to be vigilant about everything that is happening in the field.
That's really good advice, Dr. Walter. Yeah, you never know what might be available until you search. All right, somebody else is wondering if patients with CVID, not genetically tested, could potentially have WHIM syndrome that's undiagnosed.
So this is also a very good question. We actually have a Jackie in Practice issue coming out in the summer when we will have a case report on WHIM syndrome of a patient with CVID who was primarily seen by the hematologist. So he was known to have neutropenia, and his CVID got diagnosed later in life, got IVIG, and then eventually the whole story unfolded into the diagnosis of WHIM. So it is possible that when you have a CVID phenotype, but also neutropenia, that you have basically WHIM syndrome, and that should be on the differential for your clinician.
Thank you. Somebody else is wondering if there is any information on the effectiveness of COVID vaccines or Evusheld for WHIM patients.
So the vaccine responses are highly variable in this WHIM population. Not everybody has the same level of impairment of antibody responses. And therefore, you have to look at the individual and immunize and look for the COVID antibody response, the T cell response, to determine their vulnerability. If they have no neutralizing antibody present and they are hypogam in general, then the Evusheld would be of high priority for this patient. So you have to, again, look at the type of manifestations that the patient develops and then decide.
Thank you. Should all patients with chronic infections get a genetic test?
So my advice to that is that when you have a chronic infection, you first want to understand your immune system. Is there some part of the immune system missing or malfunctioning? once you understand that based on basic clinical labs, immunoglobulin levels and lymphocyte counts, vaccine levels, then it's worth going for the genetic testing and decide which route do you have to do more investigations to. So I would probably start with a very good immune phenotyping, which is easy and approved by insurance, and then go for the genetic testing.
Thank you. I got a question sent to me directly. Someone is saying that they've heard that genetic testing and genetic counseling can often be really expensive and isn't always covered by insurance. Is the path forward that Michelle spoke about, is that free or is there a cost to that? Dr. Walter, do you know, or I don't know if Michelle can
Yes.
chime in?
Yeah, I mean, I can have Michelle answer it too, but it is free.
Oh, great.
Michelle, if you want to comment on it?
Yeah, absolutely. There are a couple of eligibility criteria. So if you have an ANC count, neutrophil count below a certain number, but you can look on invitae.com/pathforward. It'll have all the information there, and you can talk about whether or not you meet that eligibility criteria. And if you have any questions, you can also email me. You can email at patientinfo@x4pharma.com or my first name last name at x4pharma.com.
Thanks, Michelle. That's great news that it's free for those that qualify. All right, Dr. Walter, we have a couple more questions for you. Somebody is wondering, could WHIM syndrome cause bone lesions?
So I'm not aware of WHIM syndrome causing lytic lesions in the bones, because the problem is mainly within the bone marrow and more of the accumulation of the neutrophils. We have an ongoing interest in understanding the histopathology of WHIM syndrome even more in a deeper level with the help of X4 and Dr. Jake Bledsoe at Boston Children's Hospital and Dr. Newberger. So hopefully we'll know more about the bone pathology as we are moving forward with that project, but I'm not aware of any like actual bone lesions.
Great. Thanks, Dr. Walter. And another one, maybe we should have led with this one, but somebody is wondering if you can explain what phenotyping is.
So phenotype is a fancy word to say that you are looking at the patient's look, like how do they look? So there are sort of like outside clinical phenotypes, the way our body is, and also laboratory phenotype, what is our neutrophil count, lymphocyte count. So that together is sort of our look of the immune system and the patient's clinical history. And that is different than the genotype, because the genotype is what we carry and we sort of carry from the birth, from the beginning inside us. So that's not gonna change. Our genotype is the same, and our phenotype could evolve from like no symptoms at all as a baby to ear infections later in life, or the warts and infections and low immunoglobulin levels. So that's sort of the phenotype.
Thanks, Dr. Walter. So phenotype is like what you see on the outside, and genotype is like what your cells are doing on the inside in like the most basic way, right?
Yes.
Great. Thank you. All right, that is all the question that I am seeing coming in. I can give it just a couple of more seconds to see if anyone has anything else that
I see that Sarah Wicks mentioned that there is a website for WHIMsyndrome.com, and there is also a private Facebook page for patient only. So this is really an exciting time when so many patients are resurfacing, and whoever in the audience have WHIM syndrome, please consider joining this group to get more information. If you have any questions, the organizers have my contact information, and I'm happy to give you personal advice. I saw one question about a patient who just got diagnosed with WHIM syndrome. We would love to hear from you and have a conversation offline. But anybody else who would like to get some answers, I'm happy to be there for them. Thank you.
Yes, and we shared the links to WHIMsyndrome.com as well as the private Facebook page, I believe, in the chat. So you should be able to find all those links there. And yes, thank you to Dr. Walter again. We were hearing from individuals saying that they are very impressed by these presentations and all the support you provide to those with immunodeficiency. So thank you, Dr. Walter.
Thank you so much. Thank you. Thank you again.
All right, so just a few more things before we wrap up. Again, thank you so much to Dr. Walter for this wonderful presentation on WHIM syndrome. And we hope you'll remember to take advantage of all of the resources that IDF has to offer. And again, to explore our research sources for WHIM syndrome, if you just go to our website, primaryimmune.org, and if you type WHIM in the search, it will show up with everything that we have from past webinars, Rare of the Rare, conference sessions, and even a couple of real stories that live on our YouTube channel. So please be sure to take advantage of all that IDF has to offer. And here's just a snapshot of some of the videos and the real stories that you'll find on our website. And again, if you have additional questions about diagnosis, treatment, or insurance related to living with PI, you can always ask IDF. So you can go online to our website and submit your questions at www.primaryimmune.org/askidf, or you can give us a call at the number on your screen. We always have individuals standing by to support you in your journey with PI. And before we close, I wanted to remind everyone that all of IDF's programming is guided by individuals and families that we serve. So many of the topics we explore through this diagnosis-specific series are applicable to the PI community. So anyone is welcome to join and kind of learn about WHIM syndrome or any other conditions that we highlight. But we're also looking to see what the IDF community needs from us. So if you can take a moment to scan the code on your screen and take our brief programming evaluation survey, we would really appreciate it. This will also be sent out in an email to all those who registered tomorrow. So if you don't have your phone handy, please keep an eye out for your email. And then lastly, we hope that you will join us for our next IDF Lunch and Learn, where we'll take a look at hyper-IgM with Dr. Andrew Jennery from Great North Children's Hospital at Newcastle University. So we have a presenter from across the pond with us next month. You can find more about our upcoming Lunch and Learns, our upcoming IDF forums, as well as Get Connected groups and other events at primaryimmune.org/events. So we hope to see you next time. And then that is all again from those of us here at IDF, and we look forward to seeing you again next time. And thank you so much to Dr. Walter and to the team at X4 Pharmaceuticals. We hope you have a great rest of your day and your week, and we will see you next time. Take care.
Thank you, Alyssa. Bye, everyone. Thank you. Bye-bye.
Thank you. Take care.
Thank you so much. Bye.